keeping an eye on imaging. Discussion and commentary based on articles from JACC, Cardiovascular Imaging.
Hello, I'm Christopher Kramer from the University of Virginia on behalf of JACC, Cardiovascular Imaging. And with me today is Dr. Tom Hatsukami from the University of Washington. And we're here to discuss his very interesting paper, which is being published in JACC Cardiovascular Imaging, regarding serial imaging with cardiovascular magnetic resonance imaging of carotid atherosclerosis in patients with between 16 and 49% carotid stenoses. Dr. Hatsukami, can you tell me why you chose this particular patient population to image?
Well, first of all, thanks very much, Chris, for the opportunity to discuss our paper, and thanks for the opportunity to publish it in JACC Imaging. Dr. Chun Yan and I have been working together for about 15 years, and we've validated and developed this high-resolution carotid MRI technique to look beyond carotid stenosis and look at the actual plaque or atherosclerotic lesion within the carotid artery itself. And once that tool was validated with histology, we decided to apply it to a variety of asymptomatic individuals to determine the natural history of carotid plaque progression. So to try to identify clinical and plaque features that are associated with more rapid progression of the atheromatous plaque, or features that may be associated with slowed or delayed progression. And that was the purpose of this study, to look at individuals with less than 50% carotid stenosis by ultrasound, and then to perform serial carotid imaging on these individuals at baseline and 18 months later, and to look at their baseline clinical plaque features to assess plaque progression.
How many patients were involved in this particular study?
So there were 80 individuals that we identified through the ultrasound vascular laboratories. And these were individuals who are typically referred because they had a cervical bruit, or their clinician felt that they were particularly high risk for atherosclerosis and decided to do a screening ultrasound examination. For example, they may have been scheduled for coronary artery bypass surgery or lower extremity bypass. And out of those 80 individuals, we were able to perform serial MRI scans in 67 of those individuals.
And some of those patients progressed over the time, and some did not. Did you find any predictors of those who progressed in terms of plaque volume?
Right. So when we looked at all of the clinical parameters, we looked at the usual risk factors: hypertension, diabetes, male or female, and all looked at their medications and their baseline plaque features. The feature that really stood out in terms of more rapid progression was the presence of intraplaque hemorrhage at baseline. Those individuals, we identified intraplaque hemorrhage even in this moderately stenotic group in about 18% of these arteries, and that subgroup progressed much more rapidly than the group without hemorrhage. And the type of progression that we saw in that group of individuals was increase in wall volume and decrease in luminal area, but no increase in the total vessel area, which would imply expansive remodeling. The other group that we identified were the individuals who were on statin therapy. Individuals who were on statin therapy demonstrated no significant progression over the 18-month period of follow-up. However, those individuals who were not on statin therapy demonstrated evidence of expansive remodeling, so an increase in their total vessel area, increase in their wall area, but no decrease in luminal volume. So it's interesting that without statin therapy, you see this Glagoff type of expansive remodeling even in over an 18-month period.
Were there differences between the findings of this study and your previous studies in patients with more severe carotid stenosis?
Yes, so this group, we wanted to focus on an earlier stage of atherosclerosis and identify which features are associated with progression. Previously, we looked at individuals with greater than 50% stenosis, and those individuals tended to have larger lesions, of course, more calcification, and had a higher prevalence of other events. And so we wanted to see if there are differences between early and late atherosclerosis. In both of our studies, intraplaque hemorrhage was identified as a feature associated with more rapid progression, and statin therapy was associated with slower progression in both greater than 50% and less than 50% individuals.
Well, great. Well, Tom, thanks for coming and sharing the findings of your fascinating paper with us at Jack Cardiovascular Imaging. This is Dr. Christopher Kramer signing off. Thank you for being with us today on behalf of Jack Cardiovascular Imaging.